Okay.
We'll take a short introduction first. Priyanka ma'am, shall we start?
Yes, dear. Please continue.
Yeah. So now we'll start with the introduction. Dr. Jagruti Patil is going to do the introduction for today's webinar. Over to you, ma'am.
Yes, thank you so much, ma'am. A very good evening to all of you. On behalf of NIMA Central and OBGY Central, I welcome you all to the 60-second webinar. Today's topic is Integrated Medicinal Management in PPH by Dr. Manisha Devkate, ma'am. Myself, Dr. Jagruti. I am coordinating today's webinar with my co-coordinator, Dr. Abhishek. First of all, it is my great pleasure to welcome all honorable dignitaries present on this virtual dais. I welcome Dr. Kamini Dhiman ma'am, President NIMA OBGY Central, Dr. Priyanka Nakle ma'am, Secretary NIMA OBGY Central, Dr. Vishnu Bhavne sir, Treasurer NIMA OBGY Central, Dr. Rajesh Utne sir, Convener NIMA OBGY Central. Also further, I would like to welcome all office bearers of NIMA Central and state bodies. I wholeheartedly welcome all the participants attending today's webinar. Welcome all. Let me brief everyone with few instructions to maintain decorum in the today's lecture. Kindly register with the name as written on the NIMA OBGY membership registration certificate, followed by NIMA OBGY registration number. Please don't hesitate to put your doubts in the chat box or you can raise your hand. All doubts will be answered at the end of the session. Proceeding further, we are now virtually going to inaugurate this webinar with Dhanvantari Stavan. Everyone can fold their hands, pray, and seek blessings from Lord Dhanvantari. शङ्खं चक्रं जलौकां ददतमृतघटं चारुदोर्भिश्चतुर्भिः सूक्ष्मस्वच्छातिरुद्यां शुकपरिविलसन् मौलिमम्भोजनेत्रं कालाम्बोज्ज्वलं कटितटविलसच्चारुपीताम्बराढ्यं वन्दे धन्वन्तरिं तं निखिलगतवनं प्रौढदावाग्निनीलं प्रौढदावाग्निनीलम्. May Lord Dhanvantari bless us all with good health, success, and prosperity. Now, I would like to brief everyone about NIMA OBGY Association, Obstetrics and Gynecological Society of India, aims to impart education in supporting and protecting the character status of Sriloka and Prasuti of the community, especially maternal and child health, prevention of ailments and diseases, their treatment with integrated approach of Indian medicine with modern science. As we know, PPH is the major cause contributing maternal mortality and maternal death. So, our today's topic is integrated medicinal management in PPH, and our guest speaker is Dr. Manisha Devkate, ma'am. It is my pleasure to introduce you, ma'am. Dr. Manisha Devkate, ma'am, had done BMS, MS in PTSR, and she is also pursuing the PhD. She is the professor and HOD at RT Ayurved College at Akola. She had clinical experience of house job in anesthesia for a year, worked with many renowned gynecologists. She had private practice for around 20 years. She attended many national and international seminars. Also, worked in capacity as chairperson, co-chairperson in various seminars. Worked as chairperson, VC nominee, subject expert, central observer, examiner for MAHS. She has experience as resource person in CME organized by RAV. Her team got first prize for the Sanhita Best Learning in PTSR organized by RAV. She had presented and published many papers. At present, she is working as professor and HOD since 2014. She is the vice president of NIMA OBGY Maharashtra State, pursuing PhD from DY Patil Ayurved College, Pimpri, Pune. So, welcome you, ma'am. It is my pleasure. Yes, you can start
Thank
the
you.
webinar, ma'am.
Before starting the session, today's lecture, I would like to wish you all a very good evening. And the outset, I would first like to congratulate the NIMA OBGY Society for conducting such webinar series continuously since this inception around 2 years before. And today's is, I suppose, its 62nd webinar. And for this, this can be called as a yajna, where knowledge transferring is done. So I congratulate PhD for especially Dr. Priyanka ma'am for taking such tremendous efforts and continuous webinar series, which will help to betterment and update our fraternity people. It will be a knowledge enhancement for us, all of us. And equal efforts are taken by Dr. Arpita, Prajakta, Abhishek, Jagruti, and Archana. All are taking equal efforts along with the senior faculty, senior members of NIMA OBGY office bearers. Our ancestors had quoted that Vidya Danena Vardhate, and this is the platform where we can together grow together and what you can say, we can impart knowledge together and update ourselves and stand in this competitive era. So thank you for giving me this opportunity, and thanks Jagruti for that nice introduction. And now I will start with the today's session. The session is actually about the medical management of postpartum hemorrhage and its integrative approach. What we will be knowing today is the definition and incidences of the PPH, the types and risk factors regarding PPH, the latest updates, and the management of third stage of labor, because it is the major part where PPH occurs and we need to treat it at the earliest. Otherwise, maternal mortality rate will be on the rise. To know the measures and prevention of PPH, and as well as to know the Ayurvedic perspectives of PPH. Everybody knows that postpartum hemorrhage is very severe bleeding after childbirth. Am I audible?
Yes, ma'am.
Yes.
Hello.
Yes, yes.
Okay. Okay. So everybody knows that postpartum hemorrhage is the severe bleeding after childbirth. It is a life-threatening condition that causes largest proportion of the maternal deaths. And the most important thing is the earliest detection and the prompt treatment, which will save the life. While defining postpartum hemorrhage, the WHO guidelines from 2012 has based it on the amount of the blood loss. If the blood loss more than 500 ml through the genital tract after vaginal delivery, and the blood loss of more than 1000 ml in the cases of cesarean section is considered to be as the postpartum hemorrhage. According to ACOG, the blood loss more than or equal to 1000 ml and the blood loss which is associated with the signs or symptoms of hypovolemia and occurring within 24 hours of the process of birthing is considered. Incidences of postpartum hemorrhage, everybody knows that the PPH is the most common cause of maternal death, which is about 35% of all maternal deaths worldwide. The incidence of PPH after vaginal delivery is around 2 to 4%, and that after cesarean section is almost around 6%. The global maternal mortality rate is 12%. According to SRS reports, that is System Regulations Reports, Registrar General of India, that is RGI, India has declined the MMR rate from 113 to 103 in 2019. And the MMR rate in 2020 was 97. That is from 2018 to 2020. When the recording was done nationwide, it is found that Assam has the highest maternal mortality rate, and Kerala has the lowest maternal mortality rate. For the first time, Health Management Information System has recorded the MRR nationwide or district-wise. And the findings suggest that almost 70% of the districts have reported the maternal deaths of above 70. And there are 128 districts out of 640 have maternal deaths that more than 200. This is a map showing the MMR rate. The lightest blue is showing the districts having MMR rate less than 70, and the darkest blue, or you can say a navy blue, is more than 210. You can see the northeastern part is having more MMR rate. Along with PPH, the other causes of postpartum hemorrhage are eclampsia, preeclampsia, ruptured uterus, sepsis, prolonged and obstructed labor, and complications of abortions. These are the 6 major leading causes where eclampsia and preeclampsia constitute around 19% of the hemorrhage is occurring, maternal mortality is occurring due to hemorrhage in 23% of cases, whereas ruptured uterus, sepsis, and and complications of abortion are allowed around 3%, while the ruptured uterus while the prolonged obstructed labor has 1% of chances of maternal mortality. When you consider about the incidences of PPH, we can see that PPH rate of around 12% is in the rural areas of India. 5.8% cases are even in first pregnancy, as we consider risk factors of multiple pregnancies or grand multiparity is considered as the risk factor. But even in first pregnancy, almost 5.8% cases are found getting PPH. The risk of having PPH in first pregnancy have the highest chances in getting PPH in second and third pregnancy. The chance is around 4 to 5%. The risk of recurrence all over is around 15%. About 93% of maternal deaths due to obstetric hemorrhage are preventable, and hence a standardized multidisciplinary approach is needed. And the most deaths due to PPH are occurring within first 24 hours of birth, that is primary PPH. Hence, prediction, early recognition, timely intervention will be helpful in lowering the MMR and lifetime risk regarding to PPH. While when you think about the etiology and risk factors of PPH, there are few issues which we have to consider, that is maternal issues, fetal issues, and placental issues. In maternal issues, teenage pregnancy, elderly primigravida, that is either age of the reproductive age, multiparity, and grand multiparity, as it is considered the patient having more than 4 deliveries. Inadequate prenatal visits, low socioeconomic status, previous history of postpartum hemorrhage, previous uterine surgeries or previous cesarean section where uterine incision is taken, then uterine malformations, fibroid uterus, previous history of instrumental deliveries, anemia, thrombocytopenia, diabetes, cardiac dysfunctions, hypertensive disorders, thyroid dysfunction, renal and liver disorders, respiratory disorders, anticoagulant therapies, viral infections such as dengue especially, inherited or acquired coagulopathies, hemoglobinopathies, metabolic syndromes, post-bariatric surgery, pregnancy after renal transplant, and multifetal gestation are the maternal issues leading to PPH. When you consider about the fetal issues, it's the polyhydramnios, macrosomia or large for gestational age fetus, and congenitally malformed fetus. Placental issues are placenta previa, abruptio placentae, placenta accreta percreta, AV malformations, chorioangioma, placental abnormalities such as vasa previa or battledore placenta. The other way we are considering is intrapartum and postpartum. Intrapartum complications such as induction or augmentation of labor, precipitate or prolonged labor, and obstructed labor. The what you can say, prolonged second stage of labor, or TOLAC or VBAC, that is vaginal delivery after cesarean section, placenta previa and placenta accreta, chorioangioma, instrumental deliveries, cesarean sections, hypotonic or hypertonic uterine actions, prolonged rupture of the membranes, PROM or PPROM, chorioamnionitis, placental abruption, and AV malformations are the intrapartum causes. When we consider about the postpartum causes, those are genital tract trauma, retained placenta, retained placental tissue, uterine inversions, subinvolution, and puerperal sepsis. Now, while considering the delivery and PPH, you have to consider, think about the risk assessment tool. Even though it has just 60% specificity, still it is seen that in 1% of low-risk patient, maternal incidence of PPH within 24 hours is still 1%. So low risk, medium risk, and high risk, this is how the risk management is done. Risk assessment is done, sorry. Low risk, singleton pregnancy are considered to having low risk. The patient with who doesn't have any previous uterine surgery, history of any uterine surgery, or no, patient doesn't giving any history of bleeding disorders, or no history of PPH, or patient is having vaginal deliveries. Medium risk, multiple gestation, previous uterine surgeries, use of MgSO4, as we have previously also seen chorioamnionitis, more than 4 previous vaginal deliveries, that is grand multiparity, large uterine fibroids, and prolonged use of oxytocin are considered as medium risk cases. While high risk, placenta previa, increta, percreta, bleeding disorders, known coagulopathies, hematocrit values having less than 30 and platelet less than 1 lakh are considered as high-risk patients. Types of PPH, those are primary, which are occurring within 24 hours of the delivery, that is postnatal period. And secondary, those are occurring after 24 hours of delivery. For primary PPH, the most common cause is atonic uterus, while for secondary PPH, the most common cause will be the remnants of placenta, the placental beads. When you think of causes of PPH, everybody knows the 4 T's of postpartum hemorrhage. First is tone, second is trauma, third is tissue, and fourth is thrombin. When you think or see the relation of symptoms and cause, because we need to, at the same time, we are going to manage the patient, while at the same time, you have to rule out the cause, or you have to find out the cause and treat accordingly. So findings in the case of PPH, that is relaxed flabby uterus, will indicate atonic PPH. If the uterus is contracted and having with bleeding, then it may be traumatic PPH. undelivered placenta or partial expulsion of the placental beads or incomplete placenta. When you observe the placenta after delivery, you can find all these things. You can judge all these things. So partial and total placenta, so that will be considered as tissue. Non-palpable fundus of the uterus, that is inversion of the uterus, and it has to be corrected. Contracted uterus along with absence of trauma or return beads can be considered as DIC, or the cause may be thrombin when you consider about the 4 T's. Now, what are the investigations which could be done for PPH? The first is hemoglobin and hematocrit values fall in HB. It may not be it may be normal initially. Then bedside tests like bleeding time, clotting time, coagulation profile may be deranged in the hemorrhage, whereas BT is increased, CT is increased, while platelet count is decreased and prothrombin time is increased. INR ratio is also increased in coagulopathies. Serum fibrinogen may be decreased or normal. D dimers are increased. Serum electrolytes may or may not be altered. Renal parameters, they will be deranged if there is severe electrolyte imbalance, then renal failure may occur. Serum lactate, it is elevated if sepsis occurs. Serum calcium, magnesium and potassium can be low in hemorrhage. Ultrasound can help to know the remnants of the placenta, adherent placenta, inversion, and rupture. Thromboelastograms were available. It's not easily available in periphery. Arterial blood gas analysis and frequency of the investigation will be as per the clinical situations. The British Committee has given the standards for hematology and recommending the maintaining the coagulation parameters in the cases of massive hemorrhage. That is, hemoglobin should be more than 8 grams per dl. Platelet count has to be more than 75 millions. Fibrinogen 1 gram per liter. Prothrombin should be less than 1.5 and APTT should be less than 1.5 into mean control. PPH management and emergency care in a bundle approach. The WHO has given components include the bundle up in a bundle approach. Non-clinical components include system integration, that is helpline should be done, teamwork, anesthetists, obstetricians, and surgeons may have to work together. Improvements, clinical components like 0-hour management, that is first response test, then refractory PPH, and supportive care can be taken. When considering 0-hour checklist, we have to think about emergency response team for the help. First of all, call for help. Then initial resuscitation for ABCDE approach, airway, breathing, circulation. IV access should be considered. Then blood sample for investigations and blood product should be arranged. Catheterization is mandatory. Vital shock index must be recorded, and quick history and rapid initial assessment has to be done to know the cause and treat accordingly. Then comes the clinical and pharmacological management, where you have to ensure the cause by palpating the uterus for atony. In cases of uterine atony, the primary response is to do the uterine massage and bimanual compression, aortic compressions, and using uterotonics. Tranexamic acid injection is been recommended nowadays 1 gram IV should be given immediately within 3 hours of delivery and repeated 1 gram IV after 30 minutes if PPH persists. If the uterus is contracted, then visualize the genital tract for detecting the trauma. And if trauma is detected, necessary intervention should be done. Evaluate the blood coagulation abnormalities. If the patient is bleeding, that is refractory PPH, then uterine balloon tamponades and non-pneumatic anti-shock garments can be placed. In cases of lower level health facilities, the proper way of transfer and referral should be done. In secondary and tertiary level settings, if woman is still bleeding, she can be taken for compression sutures, uterine artery ligation, that is stepwise devascularization, interventional uterine artery embolization, and at the end, hysterectomy can be considered. Clinical and pharmacological. Hello. Clinical and pharmacological management. This is a modified flow chart, which is an FOXY update in September 22. If the bleeding is more than 500 mg of brisk bleeding and rising pulse and falling blood pressure, then you have to consider about the resuscitation, that is call for help, bimanual massage, etc. And simultaneously you have to determine the cause. If the uterus is soft and boggy, the cause will be tone. So uterotonics has be along with tranexamic acid have to be used. So first, oxytocin can be used 20 to 40 units in 1 liter of normal saline and infuse 500 ml over 10 minutes immediately and then 200 ml per hour. That is what is recommended. Prostaglandin PGF2 alpha, that is 200 micrograms intramuscularly can be given. Methyl ergometrins can be given at 0.2 mg intramuscular or intravenous every 2 to 4 hours. Misoprostol in the dose of 800 to 1000 micrograms per rectally or 600 to 800 micrograms vaginally or sublingually can be used. Carbetocin, that is synthetic oxytocin, can be used in 100 micrograms in intramuscular or IV route. Trauma. If the laceration or uterine inversion is seen, correction of the inversion is done, suture the lacerations, drain the expanding hemorrhage, and repair the uterine rupture or hysterectomy can be considered if severe trauma. Tissue. Inspect the placenta, explore the uterus, and if needed, manual removal of placenta or curettage can be considered. If the cause is thrombin, because as blood is not clotting, then observe the clotting, check coagulation, then replace the clotting factors. Replace the clotting factors. And supply FFP. Sorry. Is it visible now?
Yes, it is visible, ma'am.
Okay. Tranexamic acid IV 1 gram should be considered in any of the cause. Tranexamic acid 1 gram should be considered as the line of treatment. If the bleeding continues, then, and that is it's severe postpartum hemorrhage, then transfuse the PCV, platelets, and clotting factors as per necessity. Consult anesthetist and surgery should be initiated. Support the blood pressure and vasopressors. Support the blood pressure with the vasopressors. Balloon tamponades, uterine artery embolization, ligation, or clamping can be considered. And at the end, compression sutures, devascularization, and hysterectomy can be considered as a surgical part. Uterine artery tamponades, cannulas, Paniker's cannula or Piley's clamps are the recent advances which can be used. Aftercare is also necessary while treating PPH. So monitoring the ongoing blood loss and treat accordingly, and referral in time is more important thing. When you consider the algorithm, as we have seen, the first 30 minutes will be considered as the golden time, and that should be there. That care should be taken to treat as earliest. Obstetricians and anesthetists should communicate each other and treat it accordingly. I won't go into these details of this. Now, considering the shock, staging of the shock. Staging is a shock is dependent on blood loss, volume of the blood volume lost, the blood in percentage or in blood loss in ml, the pulse rate, respiratory rate, blood pressure, and maternal status. In stage 1, blood loss is less than 15%, whereas that is 750 ml. Pulse rate less than 100, respiratory rate around 14 to 20, where the blood pressure is normal and the mental state may be normal or slightly anxious. Stage 2, 15 to 30% blood loss, 750 to 1500 ml of blood loss is seen, where pulse is rising, that is more than 100, respiratory rate is 20 to 30, blood pressure is decreasing, and mild anxiety is observed. When you considered it's at in stage 3, that is blood loss is 30 to 40%, it is more than 1500 but less than 2000 ml. Tachycardia, pulse rising above 120, respiratory rate rising above 30, and blood pressure is decreased, and patient is having confusion and lethargy. In stage 4, blood loss is more than 40% and it is more than 2000 ml. Pulse rate rising, that is more than 140. RR rising, that is more than 35. Blood pressure is decreased and confusion is observed. Previously, and this is previously the shock index was considered. Actually, the shock index was considered in intensive treatment units, and where it refers to the heart rate divided by the systolic blood pressure, that is HR divided by systolic blood pressure, and the normal value was considered to be 0.5 to 0.7 in healthy adults. Here, the modified shock index is then bedside assessment, which is defined as the heart rate as to mean blood pressure, with normal range is about 0.5 to 0.7 in healthy adults. The shock index is no shock, that is shock index SI less than 0.6. Mild shock, that is SI less than 1 but more than 0.6. Moderate shock, that is more than 1 but less than 1.4. And severe shock is considered, whereas the SI is more than 1.4. And you can see the mortality rate is increasing from no shock, that is the SI in less than 0.6 is 10.9%, and in severe shock, that is SI more than 1.4, the rise in the mortality is fourfold, that is 39.8%. Determining the MAP, that is mean blood pressure, is diastolic pressure plus 1/3 of systolic pressure minus diastolic pressure, and this is considered as the considered for the MAP. Now, even though this is considered for, there is another try is done to detect the obstetric shock index. A preliminary pilot study is done, which is suggestive of normal values on in pregnancy, that is 0.7 to 0.8. And if obstetric shock index is considered as more than 1, it is indicated as massive obstetric hemorrhage, and that requires blood transfusions in 80% of the cases. And this is an study done by study conducted by Lee Bass and Chandraharan in South Asian perspectives. While considering obstetric shock grading, that is also called as urgency grade, loss of blood volume, that is percentage of blood volume, is considered as also systolic blood pressure is considered. Symptoms and signs are also given, which and obstetric shock index along with the degree of shock are considered for the treatment. Loss of blood volume in between 500 to 1000, normal systolic blood pressure, palpitation, signs and symptoms are palpitation and mild tachycardia with dizziness, then obstetric shock index is less than 1 and it is compensated. While blood loss more than 1000 ml but less than 1500, the loss of blood volume is considered as 15 to 30%. There is slight fall in the systolic blood pressure, that is systolic blood pressure is between 80 to 100 mmHg, and a rise of systolic blood pressure which is causing increased pulse pressure. Symptoms and signs are weakness, marked tachycardia and sweating. Obstetric shock is index is more than 1. It is considered as mild degree and grade 3. When it is considered as the blood loss is between 1500 to 2000 ml, it is more than 30 to 40%. There is moderate fall in the systolic BP, that is 70 to 80 mm of Hg. The symptoms like restlessness, marked tachycardia, pallor, oliguria are seen. Obstetric shock index is considered as 1.5, which is moderate. And the last is blood loss more than 2000 ml, that is more than 40%. And there is a marked fall in the systolic blood pressure, that is systolic blood pressure is less than 70 mm of Hg. Signs of collapse, air hunger, anuria are seen. Obstetric shock index is considered as 2, that is severe grade 1, where immediate senior consultation and help is needed, and moderate and severe grade have higher chances of maternal mortality. Now, when considering the first line of treatment, pharmacological management, we have to consider the uterotonics and tranexamic acid. While going for uterotonics, one must know about the uterotonic, how natural what you can say, lateral or living ligatures. That is, there are everybody knows that there are normal physiological changes going during pregnancy. That is, there is maternal blood volume, it approximately rises by 50%, that is from 4 liters to 6 liters. And that is Almost 500 to 800 ml per minute is the uterine blood flow at term. The branches of uterine artery that supply the placental bed pass through the myometrial fibers, and these are arranged in longitudinal transverse or oblique directions. Following parturition, contraction and retraction of the uterus occurs, and these crisscross myometrial fibers cause the placental separation, kinking of the blood vessels, and in turn causes the occlusion of the blood flow, and thus the prevention of PPH is done. And that's why those are called as living ligatures or physiological sutures. Whereas uterine atony reflects the failure of these living ligature system to contract and retract, and there is continuous perfusion of the placental bed, and uterine atony is seen, which is difficult to predict. The uterotonics, or it also called as embolics, are the most commonly used are oxytocin, methyl ergometrin, prostaglandins F2 alpha, prostaglandin E, and that is misoprostol and carbetocin, which are nowadays room temperature stable. Carbetocin is available in India. So oxytocin is should be given at least 10 units intramuscular intravenously can be given. The dose, the onset will be occurring within 1 to 3 minutes, and it will be lasting for 10 to 15 minutes. The side effects of oxytocin are very minimal. While considering contraindications, allergic to oxytocin, which is not that much common, then cardiac dysfunctions, obstructed labor, grand multiparity are the relative contraindications. Methyl ergometrin to start with 0.2 mg intravenous or by intramuscular route is given. When given intravenously, the onset is earliest. When given intramuscularly, all onset will be after 7 minutes. The side effects will be nausea, vomiting, headache, or hypertension, and hence the major contraindication is hypertension and cardiac disease. PGF2 alpha, that is 200 micrograms intramuscularly, or in cesarean cases, intramyometrial can be given. Onset is within 1 to 10 minutes, and it lasts around 15 to 20 minutes. Side effects are all vomiting, vomiting, diarrhea, and bronchospasm. Major contraindication is bronchial asthma. Misoprostol, the dose is 800 to 1000 micrograms per rectal, or 600 to 800 micrograms sublingually or orally. The onset is 3 to 5 minutes, and it lasts around 75 minutes. The symptoms are shivering and rise in temperature. Contraindications: if patient is having any pre-existing cardiovascular disease, the use of misoprostol should be contraindicated. Carbetocin, that is which is heat stable, so it's 100 micrograms intravenous or intramuscular can be given. It has a rapid onset of action, that is within 2 minutes of either both IV or intramuscular route. It's having long half-life, and hence it is more preferable nowadays. Generally well tolerated, but some symptoms like vomiting, abdominal pain, headache, tremors, dizziness can be seen. Serious contraindications: while considering contraindications, serious cardiovascular risks are considered. Then hepatic and renal disorders, epilepsy, hypersensitivity to carbetocin or oxytocin can be considered as the contraindication. Pregnancy and labor before the can be all these are considered as hypersensitivity to carbetocin, oxytocin, or any other such products compositions can be considered as the contraindication for carbetocin. Now, the most common and important part nowadays, it is considered as tranexamic acid in the management of PPH. There are few studies done on the tranexamic acid. As you know, tranexamic acid is an antifibrinolytic agent that blocks the lysine binding sites, and it reduces the bleeding related to mortality in women with PPH, especially when administered soon after delivery. And according to RCTs, that is randomized controlled trials done so far, reported that PPH prevention after cesarean section deliveries, the women who have received the tranexamic acid has significantly less postpartum blood loss, and there is no increase in the severe adverse effects. The WHO recommends that women with PPH, if receive an intravenous injection of 1 gram of tranexamic acid soon after giving the birth, followed by the second dose, if the bleeding continues, the second dose should be given after 30 minutes, or if the bleeding restarts within the 24 hours after giving first dose, then second dose can be repeated. The urgent treatment is helpful, and it is most effective if given early. It is seen that there is no benefit when drug is given after 3 hours of the onset of bleeding. Hence, monitoring is the most important thing. There are few studies which we are going to see about tranexamic acid. It's a multi-center, double-blind, randomized control study, which is done with 2 parallel groups, including almost 4,524 women who had cesarean deliveries of around 34 weeks, were administered tranexamic acid intravenously just after birth. And according to the study, the group which is received tranexamic acid has promising results preventing the PPH. Second study, which was a double-blind randomized controlled trial, which included 4,079 women, having amongst them 3,891 had vaginal deliveries, and they have given a group has been given tranexamic acid, and which is shown that it has a lower the rate of postpartum hemorrhage as compared to that of placebo group. Among women with results showing among women with vaginal deliveries who received prophylactic oxytocin, the use of tranexamic acid reduced the rate of PPH of at least 500 ml. That was significantly low compared to the PPH rates with the placebo. Another study was also a double-blind randomized controlled trial, which is given in cesarean deliveries, and it has also shown that there is a significant lower incidence of estimated blood loss less than 1,000 ml, and there is no need of any PCV transfusion within 2 days of the postpartum period. So these are the studies which are showing the use of tranexamic acid. The another considerations along with uterotonics, tranexamic acid, the another considerations are bimanual compression, which are not, you can say not exactly medical treatment, but it is part of the management without medication, and it can be done by anyone with proper training, anyone can do it. So steps of manual compression: first, empty the bladder, wear the sterile gloves, insert the gloved hand into the vagina, and apply the pressure at the same time from the abdomen, and try to compress the anterior-uterine wall. Secondly, which can be considered as the mechanical and surgical methods of management of refractory PPH. Those are, the first one we have seen is bimanual compression. second is uterine balloon tamponade, and third can be aortic compressions. So uterine tamponade is that is a study done, a systemic review and meta-analysis have reported that the overall pooled success rate of uterine balloon tamponade in the treatment of PPH was 85.9%. Women with PPH due to uterine atony and placenta previa had higher success rate than those patients having placenta accreta or written products of conception. The uterine artery tamponade can be considered as the subsequent treatment for treating refractory PPH, as well as the uterine artery embolization can be considered as the treatment for refractory PPH. Pernicious cannula can also be used for the PPH management. It creates any vacuum suction cannula system for atonic PPH works on this following principle. That is, after insertion of the cannula into the uterine cavity, a negative pressure is applied and the soft tissue gets sucked into the small holes of the portion and thus become adherent, and thus compression of the uterus occurs, and you can say the PPH can be avoided. And the second, which is not a surgical management, but it can be used while transferring especially while transferring the patients. Non-pneumatic anti-shock garments can be used. It is a unique and low technology of life-saving first aid device that is used in women with obstetric hemorrhage. It can be applied by anyone, even those with very little medical knowledge. It has unique role and shock management because it is meant to use with other technologies, but it is meant to use with other technologies. Currently, the only tool which aids in stabilizing the pulse and blood pressure after the woman has gone into shock from a obstetric hemorrhage. It is mentioning the numbers which can be used accordingly. The one number that is on the leg part can be used. If time permits, we will see the videos of this. The next is, these are the common circumstances where we have seen the management is like that. But there are some special circumstances where there is no set protocols, where recommended protocols are not there, such as multifetal pregnancy, VBAC, and other high-risk pregnancies. There are some evidences which you can see. In cases of multifetal pregnancy, all fetus has to be delivered before the administration of oxytocin drugs and avoid the intrauterine asphyxia. Methyl ergometrin should not be given in women with hypertension, cardiac diseases, severe anemia, Rh negative mothers. Injectable prostaglandins cannot be given in patients with high risk, special situations where women are at high risk of PPH, but it should not be given in the woman having bronchial asthma or cardiac diseases. Misoprostol is a synthetic analog which is safe for women with bronchial asthma and heart disease, which can be used in these cases. In obese and nulliparous women undergoing emergency cesarean delivery, single 100 micrograms of IV carbetocin infusion is more effective than IV oxytocin infusion for maintaining adequate uterine tone and preventing of PPH. Carbetocin is as effective as oxytocin in the prevention of PPH, especially with women with preeclampsia and without any association with developing of oliguria or anuria. Now, what is the management for delayed PPH? As everybody knows, delayed PPH, hemorrhage between 24 hours and 6 weeks of, between 24 hours to 6 weeks of postpartum is termed as delayed PPH. The common causes include the retention of placental tissue, membranes, and infection leading to endometritis, endomyometritis, parametritis, etc. Bleeding can be sudden, profound, resulting in rapid cardiovascular collapse. Septic shock may be considered. The investigations in these cases are similar to atonic PPH, whereas some additional investigations to know the septic foci and culture sensitivity to know the exact antibiotic therapy are mandatory in such cases. These cases may be the early features of DIC. So blood coagulation profile should be done the earliest. The main stay of management is resuscitation and fluid therapy, broad spectrum intravenous antibiotic therapy, which will cover the gram-positive, gram-negative, as well as the anaerobes. And if after the sensitivity reports, you can change the antibiotics. Evacuation of the uterus or surgical management of the septic foci should be done. Individualized surgical procedures may be adopted depending on the case. Uterotonics and tranexamic acid can be used. Prevention of PPH is the most important thing which is to be considered. As we have seen the risk assessment tool, everybody has to consider the risk factors before treating any patient. So for pregnant women, birth preparedness, complications and readiness for the pregnant woman, family members and service providers has to be done. Adequate antenatal checkups and investigations need to be done. For healthcare providers, adequate number has to be there, skilled, and that those to be skilled and updated. Emergency response team has, sorry. Is screen visible now?
Yes,
Hello.
it's
Yes.
visible, ma'am.
Okay. Sorry for the disturbance. So emergency response team should be kept ready. The facility readiness should be there. Adequate infrastructure, PPH kit, emergency kit should be there. Appropriate equipments, instruments, and consumables should be ready. Appropriate medications such as uterotonics, tranexamic, should be in the stock. Special requirements like uterine balloon tamponades or condom catheters, non-pneumatic anti-shock garments, suction cannulas, or transvaginal uterine artery clamps such as Piley's clamps should be kept ready. Blood and blood products availability should be there, and PPH checklist should be done, and history should be taken properly. Protocols and procedures. Partograph is while in intrapartum period, partograph is mandatory. Cardiotocography especially in high risk patient situations should be done. Active management of third stage of labor in all the cases is to be done, and use safe birthing checklist and surgical safety checklist should be considered. Anticipate, prevent, and perform. This is the motto to prevent the PPH. So for that matter, risk assessment, that is detailed history, clinical evaluations, and relevant investigations should be done. Optimal prenatal care should be taken. Correction of anemia and nutritional management should be done in time. Management of medical conditions should be done in proper, if needed, multidisciplinary approach is considered. Now, when you think of prevention, we have to think of Ayurveda because Swastha se Swastha Rakshana is the motto of Ayurveda. Now, while considering the Ayurvedic perspective of postpartum hemorrhage, we cannot exactly label a single disease where postpartum hemorrhage can be labeled in according to Ayurveda. That is my thought. Somebody may disagree with me. So for that, our ancestors, that is Charak Sanhita, our Bruhatrayi has been mentioned that nahi vikaranam akushulo janhyat kadachana sarva vikaranam namato asti dhruva sthitihi. Meaning that it is not necessary that every disease can be labeled, but you can consider the treatment and its samprapti according to the dosha dhatu samurchana which is occurring in it. And thus, according to me, postpartum hemorrhage cannot be labeled, and it's not necessary to label it according to Ayurveda. But while considering of PPH or complications or the causes of PPH, we can consider we have to consider about the Prasava Vyapadas. Especially when you consider Prasava Vyapadas, we get the references of Yoni Kshata, Yoni Bransha, and Aparasanga. These are the major things we consider or regarding in context of the context of postpartum hemorrhage. Yoni Kshata, that is lacerations or trauma to the genital organs. Here Yoni meaning Travarta Yoni. Hello. Here Yoni meaning Travarta. Any lacerations, vaginal lacerations also. Up to that you have to consider in Yoni Kshata. While considering Yoni Branch, I think they have given the treatment that Swasthane Sthapayet. So most probably prolapse, genital prolapse cannot be easily replaced. So the replacement is easily possible of dislocated fundus, that is
Hello, ma'am.
inversion of the uterus, and this can be repositioning is easily
Hello, Manisha ma'am.
possible. So we can think Yoni Bhausha as inversion of uterus. This is again my view. Somebody may disagree with that. We have given the Apara Sangha, that's one of the causes of that is Apara Sangha, where yes, yes.
Yeah, ma'am, your voice was breaking at that time. Now it
Hello.
hello, ma'am.
Hello. Hello. Am I audible?
Yes, ma'am, you're audible. You can resume the
I think
lecture.
my internet is unstable.
Yes, yes, ma'am.
Okay. Okay. So for considering the Prasava Vyapadas, Apara Sangha can be considered as Apara Sangha, that is remnant of tissue, is one of the causes of postpartum hemorrhage, and that can be considered in Ayurvedic context regarding the postpartum hemorrhage. So they had given the treatment of Vilambita Avi and Apara Sangha also. So the Aparasanga treatment is like Dhupana, and the last is manual removal of placenta, which we have considered. That is Hastena Sarpishaktena. That is what they have mentioned, that Apara should be removed. The method of removal of Apara, which is again coincides with the modern treatment. So this can be considered as one of the parts of postpartum hemorrhage. Then Sutika Makkala, where hematomas can be considered, or it can be considered where the collection of Rakta Sanchiti is there along with Vata Vruddhi. So Shula is there, and especially when you see the description which is called Prajatayascha Narya Raktam Sanyuta Raktam Vayuna Saddeshagateena Sanruddham Nabhe Adha Parshvayoho Baste Shirasi Granthim Karoti. So you can consider rupture of uterus or collection of blood in the uterine cavity, that can be considered in this as Sutika Makkala. Other Sutika Upadravas we can consider as Rakta Vidhradi, where Strinam Apaprajatanam, that is when the delivery process is not proper. So Strinam Apaprajatanam Tatha Ahitaihi Dahajvara Karo. That is what we described as Rakta. These are the symptoms which are considered in Dahajvaradi, so which we can consider as the puerperal sepsis, which may be the other cause of the maternal mortality. And as we know the Ayurveda, the paricharyas are the boons given by Ayurveda. As we know, Paricharya Palana has its important. Garbhini Paricharya has mentioned by all our Granthakaras, and in short, the aim of Garbhini Paricharya is Anupaghataya Paripurnatvaya and Sukha Prasavaya. The Sukha Prasavaya itself considered about the normal delivery, or you can rather say the effortless delivery, which is considered in the, and of course when we are saying Sukha Prasavaya, that is it is devoid of any complications, that is meant by Sukha Prasavaya, and hence Garbhini Paricharya, we have seen the Basti Chikitsa, Pishtu Chikitsa have also mentioned in the last phases of the Garbhini Avastha. So this can be considered as the boon to prevent the PPH and maternal mortality further. Prasav Paricharya. In Prasav Paricharya, they had given many things, that is Sutikakara Pravesha, where in 9th month, because as we have considered, many Granthakaras are considering 9th and 10th month as the major period when delivery occurs, that is up to 40 weeks, it is considered. So according to that, Sutikagara Pravesha has been considered, where many medications are considered as the Prasava Sambhara Dravyas, which are considered, where we can see the medications which are especially used in daily routine are there, which will help to. And the next part is Prasava Paricharya, where the process of Prasava is mentioned, that is especially when we consider as a Prasava, we consider it as Prajayani, Upasit Prasava and Prajayanishamana Avastha. And this while Avi Pradurba, when Avi Pradurba occurs and cervical dilatation occurs, then the show is considered, show is seen, then it is considered as Upasthit Prasava Avastha, where the treatment starts that Avi Pradurba, the way is to consider the Uttana Shayana, that is what the position of the female should be, and she should flex her thighs on her abdomen, that is lithotomy position considered in modern science, and she should bear down. So while bearing down also, they had given the method of bearing down, that she should bear down very slow, pain should be taken, and as the process advances, she should use that is what is Shanai Shanaihi Pravahayet, then it is Gadhatama and Pragadha. That is what is being mentioned, that this is the exact method. So it should not be too early. The enforcement of labor should not be too early, and the method should be proper. Secondly, they had given the mention in Prasava Paricharya is Yoni Puna Puna Prasarayet, which will prevent the injuries or tears of the tears to the genital tract, that is that can be considered. Secondly, the lithotomy position also helps in apana anulomana, and the in Garbhini Paricharya also they had given Basti Chikitsa, which causes apana anulaman. As we consider, delivery is a process which is occurring due to apana vayu, and apana vayu is the major factor, and anuloma gati, that is the proper descent of that fetus or products of conception are necessary for the proper expulsion, and hence that is considered as. Secondly, in Prajayini Avastha, they had advised to Chankramana, which is helps in this that gravitational force is helping to descend the or proper what you can say, the proper descent of the head, and thus it can be chances of normal delivery will be improved, and it will give proper pressure on the cervix, and dilatation will occur in proper, avoiding further complications. Secondly, while considering Prasava Chikitsa, they have considered the Vilambita Avi, that is prolonged labor pains, which are to be treated in time, and that's why they had given many treatments like Dhupana Chikitsa, Nasya Chikitsa, Pradhaman Chikitsa, etc. have been, Lepan Chikitsa, Langli Lep has been given. All these treatments have been given to prevent the Vilambit Avis. So these are the considerations where we have to first try to prevent the complications, so that maternal mortality will be reduced. While explaining Garbhini Avastha, they had explained that Garbhini is Tailapurna Patra. She is like when any pot filled with oil, there is a higher chances when we try to move it, there are higher chances to spill it, and it's like that it is a very crucial time period for in woman's life, so she should be treated like that. And while giving Prasava Paricharya, they have also mentioned a special attendee has to be is expected to be sorry, expected to stay with her, and that special attendee or whoever female attendee will be there, she should be having experience of delivery. She herself has undergone the delivery, so she knows the pain, she knows the do's and don'ts properly, and so that she will help her to deliver in a proper way. So this is how Ayurveda has considered it, and this is how primary PPH can be prevented. While in Sutika Paricharya, if Sutika Paricharya is properly followed, then only secondary PPH can be avoided. That's what we can say. While considering of Sutika Paricharya, Sutika Vakya, Sutika can be labeled only after total placental delivery has occurred. So that is what is considered. While considering Sutika Paricharya, we know Garbhaya Shodhana Dravyas, Dipan Pachana Dravyas, and the most important is Ashwasan Chikitsa is to be considered as the one of the parts of Sutika Paricharya. There are few research articles which have acted on which can be considered. Shall I go ahead with those? Hello. Shall I go ahead with the risk, or shall we? Do you want me to continue?
Yes, ma'am, you can continue.
Okay. There are few research articles which are related to the secondary PPH. There is one study which I have seen regarding Ayurveda, the study of efficacy of Panchakola Churna in Sutika Paricharya in decreasing the incidence of secondary PPH. The research was done by Dr. Gholap, Dr. Mangesh Patil and et al. It is published in International Ayurveda Medical Journal. The study was a double-armed controlled clinical trial to evaluate the efficacy of Panchakola Churna in decreasing the incidence of secondary PPH. In that study, the sample size considered was 1000 PNC patients having history of normal delivery at sub-district hospital in Manmad. These patients were divided into two groups. A groups where daily 2 grams of Panchakola Churna was given with warm water for 10 days, and injection pitocin 10 units intramuscularly was given after delivery. So diagnostic criteria was PV bleeding after 24 hours and before 45 days. That was the diagnostic criteria considered. And the blood loss considered was if it is more than 300 ml per 24 hours, then it is considered, these are the diagnostic criteria which are considered. The assessment was done on the basis of pain in abdomen, appetite, lactation, and involution of the uterus. Discussions. The results were seen that 8 patients were presented with secondary PPH. In the total, 8 patients were presented with secondary PPH, whereas in group A, trial group, only 2 cases were reported. And so the result conclusion was given regimen is significantly helps in reducing the secondary PPH. Then there is another study, the role of Ayurveda in managing PPH, a review, which was considered, which was done by Dr. Shilpa Patil and Dr. Shweta Patil. The article discusses the traditional Ayurvedic approach in managing PPH, including specific herbs, diet, and lifestyle modifications. Ayurvedic treatment helps in reducing the it is seen that Ayurvedic drugs help in reducing the excessive bleeding after birth and improve overall maternal health. So in such there are few case reports which are seen, but the treatment was given along with modern parts. So I am not going to discuss those case reports here. So what at the end, what is the take-home message? The proper following of ANC care, detecting high-risk patients, following of active management of third stage of labor, finding out the cause of bleeding as earliest as possible, and following of hemostasis for the management, following of the hemostasis, that is the stepwise management of PPH, that can be considered as the major part. What is hemostasis? H stands for help and hands on the uterus. E stands for establish the etiology, ensure ABC, ensure the availability of blood and ecbolics. M stands for massaging of the uterus. It should be done continuously. O stands for oxytocin infusions and the other uterotonics of either intravenous, intramuscular, or per rectal. S, right time shifting of to the theater, anti-shock garments, and considering of the transfer. T stands for tamponades, uterine packing, exclusion of tissue trauma, and use of tranexamic acid. A stands for applying of compression sutures like B-Lynch or modified B-Lynch, etc. Systemic pelvic desvascularization, that is uterine, ovarian, and internal iliac. Intervention radiology, I stands for interventional radiology, where uterine artery embolization can be considered. And S stands for subtotal or total abdominal hysterectomy. This is how PPH can be managed effectively. These are my references. So if time permits, I have taken some videos. If time permits, we will continue, or shall I stop here? Thank you.
Thank you so much, ma'am, for the wonderful session. Ma'am, you can share the videos. We would definitely love to see those.
Okay. Okay, first we will see the mock drill and then we will go for another. I will try. If it works, it's fine.
Meanwhile, I would like to thank ma'am for the wonderful session, and we are now open for question answers also. We would start with the question answers after the videos are shown. So any queries you have, kindly put it in the chat box and we will address all the queries.
Is it visible?
No, ma'am.
Okay, we will try. Try if it works, it's fine. Otherwise, we'll stop here. I'm not able to share it.
Okay, ma'am. Ma'am, alternatively, you can share those videos later in the group also so that everyone would be able to view it. So that is also something which we can do. So,
Okay. Hold it on. It is
um,
included on the power presentation also, so it won't be okay. Okay, I will
yes,
try to.
yes, sure, ma'am. Ma'am, thank you so much for the wonderful session. We learned a lot today regarding PPH, all the life-saving measures, the causes of PPH, and everything which we need to know. So now I'm opening this for question and answer series. So one question which I wanted to ask from my side, I'll take with that first. Uh, how to write high risk consent in PPH according to the stages of PPH, like stage 1, stage 2, stage 3, and stage 4? Which points are the ones which we should include? Because as we all know, this is little bit goes in the medico legal. So we have to protect ourselves also.
I could get the exact what you want is the way you have to take the consent. Is it?
Yeah,
Am I right?
I wanted to just understand in cases of like mild PPH, moderate PPH, severe PPH, or stage 1 to stage 4 PPH, depending on that, which points we should include in the consent, anticipating that these complications can occur in the patient.
See, for low risk patient, it is not possible to consider that you are not able to explain all the things. But in high risk patients, it is easy to consider, like in preeclampsia. it is easy to explain the relatives about the known complications, and then you can include it into the consent in their words. That is in the language known to them. That is the most important thing, what I think.
Yes, ma'am. Ma'am, and could you just share when a patient of PPH comes, so how to assign responsibilities? Like what should be the responsibility of the doctor? What should be the responsibility of the nurse? And which things should be done, immediately, which can be kept for later? Because it is a chaos, when such things happen.
So that is what when obstetric mock drills are very necessary, and you have to consider the roles beforehand. So mock drills are very useful because in emergency it is not possible. So training should be done beforehand. The PPH kit should be kept ready, which would include the non-surgical thing, non-medicinal things, and medicinal things. Then it's easy to create a emergency response team. It's you can do if, and it is, of course it is possible in tertiary centers. It is not easily possible in primary centers, but this can be considered. And the what says so the responsibility can be considered is like intravenous infusions, blood sampling, and all these things can be done by sister. The staff nurse can do all these things. The establishment of what you can say, the estimation of blood loss, this thing can be done by sister also. Then that is EBL. It can be done by sister also. And while ruling out the cause or atony, it is to be done by the doctors. That's what I will think, because it is easier for a doctor to. It will be easy to. It's doctor's duty to consider, diagnose the patient and rule out the cause of what you can say, to rule out the cause of PPH. So major part, the and you have to order the continuously go on ordering what should be done by whom. That is what should be done. Because if you just say give oxytocin, so who is going to? Two people are running about after oxytocin will not help you. So you have to consider that your team members are, these are your two members, and she is going to consider look after the investigation part. She is going to look after the administration part, administering the drugs. This can be done, and thus so for that mock drills are very necessary, which will help you to prevent the chaos.
Thank you so much, ma'am, for all the nice answers. Uh, so, ma'am, there are no new questions in the chat box. So, should we
Okay.
conclude the webinar?
Okay, will do. Thank you.
Yeah. Thank you so much, ma'am, for the wonderful session. We really had a
Thank
very
you.
nice time today, and we are going to take home with us a lot of knowledge and lot of enlightenment on the topic of PPH. So, thank you so much, ma'am. So, I would
Thank
now
you.
proceed with the vote of thanks. I'm Dr. Prajakta Patil. On the behalf of NIMA OBGY Central and NIMA Central, I thank all the office bearers of NIMA OBGY Central, Dr. Kamini Viman ma'am, Dr. Priyanka Nakre ma'am, Dr. Vishnu Bhavne sir, Dr. Rajesh Utane sir. I thank all NIMA central and state bodies, office bearers and dignitaries. Today's lecture was a great success due to our eminent and knowledgeable speaker, Dr. Manisha ma'am. Thank you ma'am for all the guidance in today's session. I would like to thank the coordinators for today's webinar, Dr. Jagruti and Dr. Abhishek. Our technical support, Mr. Akash. Thank you so much. Without each one's coordination and support, these webinars are not possible. Thank you each and every one who attended today's webinar. All the delegates, thank you so much. Without you all, obviously these webinars are not at all possible. So this
Thank
brings
you.
us to the end of today's webinar, and I hope everyone has had a great time and learned a lot. So we will see you next in our next webinar, which is there on 26th of October. that is very soon. So with this, I conclude today's webinar. Hope you all have a great evening ahead. Thank you once again, Manisha ma'am, and thank you all the
Thank you.
delegates for patiently attending. Thank you, ma'am.
Thank you. Thank you.